Assalamu alaikum, everyone, and thanks very much again for PSH for inviting me to talk on this. A rather unusual subject, not very exciting for many of us, but indeed very important and very relevant to all of us, particularly in where subcontinent finances and resources are limited. And to be honest, even in the countries where resources are not very limited, this is something that research has proven that is very well required. Okay, my intention was to do a workshop, which is case-based scenarios, and we do live sessions with the help of actors, with the help of trainees, and we do scenarios. And because by now, through PSH and ECHO, we have delivered enough on palliative curriculum, and we felt that perhaps it's the time that we now start to imply that knowledge to the real scenarios. However, it's a 40-minute session, and most of us probably be sleeping by the end of it. But I think let's see if we could keep everyone awake. And it's just after lunch, I'm afraid, so that's not going to help either. All right, let's start. In the first part, what we want to talk about is, do we actually need palliative care in hepatology? Is there a need? And why? Why there is a need? And if there is, why do we actually need it in Pakistan in particular? So hepatologists and palliative care, it's the third most common cause of death. Importantly, in the people of working age, you and I all know that the patients that we have in our clinics who have either hepatitis B, hepatitis C, decomp liver disease, HCC, they're actually very young. And look, the impact is not only the generation so that the patient belongs to, but also his generation before, like his parents, who he's now supporting, and his children, the next generation that he will support, because he's usually, we've seen this, is a breadwinner, single-handed. So the impact is huge. Mortality worldwide, and this isn't just Pakistan, either it's a UK or it's states, it is very, very high, more than 1 million deaths worldwide 10 years ago. We're waiting for the latest data to come up. In United States, liver disease accounts for almost 200,000 hospital admissions a year. So it by no means that we can just say one country is struggling, one healthcare resource is struggling. It's actually well-developed countries are equally on the same. So do we actually need it? Well, yes, over 70% of the people with liver disease, they die in hospital. Do they have to? No, not necessarily. Let me share this data with you. This is UK Office of National Statistics data, Public Health England. And look at this, 22% of the people with liver disease have 5 or more admissions before they die in the hospital. So this is so blatant fact that there were at least 5 opportunities for these patients, for the healthcare workers, that they could have seen or known that these patients are not going to be doing very well. Okay. The other important fact in these, that 80%, if you notice this, they die in emergency department, 80% of them. This is something which is worth keeping in mind. More than 1 in 10 deaths of the people are in their 40s from liver disease. So what about Pakistan? We've seen the West. We know what the demographics look like in UK and states. Let's have a look at Pakistan. Why should we? And this time we're not going to talk about finance, resources. Let's just go down to the very hardcore figures. Okay, let me share some from Department of Health, Pakistan. And if you look at age distribution and compare it with similar size countries by and large, either economically or comparing it with developed countries as well, Pakistan being green, understandably, you would see that in the age distribution, Pakistan is by and large, most of the population belongs to between 20 to 49 years. And that is again the largest population who actually is dying from any other disease in the world. Okay. If you look at disease incidence, again, Pakistan, you can see that liver disease is 5 times more mortality-wise incidence, which is globally, if you compare. Now, just focusing on Punjab, PSH 2021 being in Lahore, we did about 4 years ago, 2017, Punjab hepatitis survey. And with what we known at that point, that if you look at Punjab population and we look at only Hep B and Hep C cases, were around more than 10 millions, with around 2 million cirrhotics that you currently have in Punjab. And we know that 20% of them would decompensate. No health system would have the capacity to actually deal with this. So we know that younger people are dying. We know that this disease is really like an epidemic, should you like. We need to control it. So what is the problem then? Why are we not controlling? And if you look at the studies, come more and more in the last 4 years ago, Lowe and his team, they looked at why we actually do relatively bad in palliative care. And if you look at the factors, the first thing that comes is a lack of clinician knowledge. And this is the reason why I have been really trying to emphasize this fact in the last 3 years. And I'm really grateful for PSH to accept that argument and included this as a part of training in their conferences, and CPSP has also included this, I was led to believe, this year in FCPS curriculum, because the first point that comes out why we do bad in palliative care and liver disease is actually lack of clinician knowledge. Second was ignorance of the benefits of it, really, on the symptom control, and lack of skills and confidence in initiating the advanced care planning. Okay, that we're going to talk about this in detail. So does it actually help if we're going to train people? Are we really looking at that we're going to achieve something here? So University of California, what they did, a very nice work and some very positive outcomes here. They looked at 157 admissions coming to hospital, and they said, what we're going to do, as much as we're going to assess all these decompensated liver disease or ACLF patients, we put them in an integrated pathway with the palliative care team. So the day they come and land in the hospital, we're going to provide both, so acute care as well as palliative care. And what we're going to see if there is a difference in the outcome, and see, of the total people enrolled, only 10% were considered suitable for liver transplant. So all these sick liver patients who were admitting to the hospital, 90% of them weren't even suitable for transplant. So, but we still need to look after them. And these patients have done actually very well, who were integrated with palliative care team, with symptom control, early discussions, hospice care, and even hospice homes or support at home if that's what patients have preferred, or their families. Okay, so now we know it works. Now we know there is a need. So why don't we actually do well? And this is like multifactorial thing. Largely, I normally divide them into 3 categories. So one is your patient and disease related factors. The second is profession related factors, means involving us. And lastly, our external factors. But before we go down there and discussing these factors, I wanted to share our first case of today's talk. Sajna, who is a 56-year-old woman. She is known PVC for many years. She's on maximum medical therapy, also 50 milligram per kilo. They've tried obeticholic acid for her, but when she became cirrhotic and decomp, it was stopped. And she had ongoing issues with encephalopathy and poor nutrition. multiple admissions to hospital in the last 6 months with encephalopathy, despite being on lecturelose 3 times a day and on rifaximin, and maximum as you could do, really. She isn't a transplant candidate for several reasons. Finance and the donor availability is one of them. Okay, so she admitted again, few days with the drowsiness and altered speech. She's having multiple falls at home, and in the last few months in particular, and she walks with a carer. You've examined her, she presented to your clinic, the temperature is 36.8, her heart rate's 88, blood pressure is 92/74 with a respiratory rate of 16. She's drowsy, she's dehydrated, she has a flap, and jaundice is ++. All right, you do some blood tests, hemoglobin's 11, white cell count 7, platelets 64. We do the LFTs, bilirubin's 9.6, ALT 56, ALK phosphorus 660. Renal functions, sodium 128, potassium 4.5, urea low, so as creatinine, again suggesting poor nitrogen balance, poor nutrition really, and INR is 1.9. You've done a chest x-ray, it was clear, there was no infection. You've done ultrasound scan, you wanted to make sure there's no obstruction there, and it isn't. And liver, of course, looks cirrhotic, there's a patent portal vein, there's no thrombus, and there's no focal liver lesion. She had another CT scan, because every time she comes in, she's drowsy, she goes to a different hospital, a different doctor, a different clinic, and she ends up having a CT scan. Nonetheless, it does not show any acute pathology. So by now, just have a moment back and reflect. This poor lady had many admissions in the hospital, same problem. We know at the outset she can't afford transplant, and now her health wouldn't allow transplant anyway, right? And she, every time she goes in, she had magnitude of blood tests, she had magnitude of assessments, ultrasound, CTs, chest x-rays. Every time she goes to, she has all those tests. This is a barn door classic patient that you and I see. Don't we all know Sajda very, very well? Okay, moving on. She gets admitted to hospital again, of course. Well, what would you do? Family is there. What can you do? She was dehydrated. We give IV hydration with some human albumin solution, lecturelose, QDS increased to 40 mils. We gave enema twice a day and rifaximin, and she's now passing 3 stools a day. There is subtle improvement, but I'm afraid with day 7, and she's not able to still walk independently and continues to be drowsy, at least intermittently. Of course, the son is not happy. The poor guy is frustrated. It's coming to the end of the tether. He has got ongoing financial issues, surprise, surprise. And he wants to speak to a doctor and wants to know the following. All right. Why my mother is not improving, doctor, this time, right? And wouldn't it be better to transfer to HDU and ITU? She's day 7 on the ward. Why isn't she's getting better? And by the way, I have a friend in the media, in the press, who can talk to hospital administration and they can sort the ITU admissions. That's not a problem. It's actually a live case, and you may think it's not a made-up case. And he also asks, I want my mother for full escalation, and I want full resuscitation every time she comes to hospital. You haven't got any right, doctor, to let her die, all right? If anything happens, I want every resuscitation. And to be honest, last time doctors talked to us about this, she improved, she got better, she talked to us, and we took her home. So she wasn't really dying, and therefore I'm just gonna let it be there. Okay, he's also heard, and that's important, quote unquote, doctors talking about palliative care on the ward round. And he does not want the treatment or end-of-life care to begin, because palliative care is end-of-life care. This means that doctor will stop doing everything and her mom will suffer and die, right? Question number 1 for all of you. Palliative care is the care given to patients in the end weeks of life. End-of-life care is the care started in the end days or hours of life. Palliative care and end of life are interchangeable terms. All investigations and treatment must be stopped when palliative care begins, and palliative care should be offered to patients awaiting transplant. Now, we couldn't really have a live tool where you guys could say yes or no, but palliative care is the care given to patients in the end weeks of life. No, that's not quite true, and I'll talk about this in a minute. End of life care is only given in last days or hours of life. No, that's not true either. Palliative care and end of life are interchangeable terms. Well, they shouldn't be really. There's a very clear demarcation. All investigation and treatment must be stopped when the palliative care be. No, that's not true either. Should palliative care be given to all patients, including the one awaiting transplant? The answer is yes, of course. And we will talk about this with evidence. Okay, let's go back. Is end of life is the same as palliative care? One of the things he was worried about because he heard about palliative care. So NHS definition, the official definition, is that the care refers or given to the patients with prognosis of 12 months or less. So very well-defined, limited end outcome. Cancer patients, for example. Palliative care, however, is not necessarily just for cancer patients. What palliative care is, it's an approach, really. It's the way the doctors are going to look after their patients. And this means a quality of life in what we've seen as a life-limiting or life-threatening illness. This doesn't have a defined boundary, really. Your patient are still able to live 2 years, 3 years. That doesn't mean that I'm putting stop to any treatment. That doesn't mean I'm stopping any investigation, really. But I want to talk to patients and their relatives, and I want to know then that things are not going to get better. Tell us what is important for you. Tell us how we can help. And that's what's important, really. Okay, Sajda, why is she not improving this time, really? Every time she improves, and doctors say this. And the reason for this is that the younger patients, below 50s, for example, they have a very variable trajectory. And this is something that I always talk on this. If you consider blue line, these are the cancer patients. So you have functionality of patients is there, and prognosis in time is here. So cancer patients carry on with a high function and they decline suddenly. Yeah, very expected. If you look at old age, very, very frail patients, they start with very low functions, but they tend along, carried on, and then eventually die or fade away. Now, your liver disease is this. So you come, you deteriorate, you improve, go back home. Come back again, improve, go back home. But what's very, very relevant here, that none of these admissions have brought the line back up to that standard. Every time they come, and this is what you need to tell her son, that look, you're absolutely right. But if you look at the evidence that every single admission they come into hospital, it reduces their chances of survival, and sadly, it takes them even closer to the inevitable. Okay, so why not ITU? She improved last time. Why can't she go to ITU this time? Frailty. Remember I said she had multiple falls at home? Remember I said she's now walk with the help of 1 or 2 carers. Frailty is a state of increased vulnerability. And this is again something that you really do need to tell your patients and talk them through. There's a clinical frailty score. And if you look at score 5, which is really that you either need someone to walk you. So if they are walking in, holding 2 of their family relatives, or even one holding with both arms, you don't have to work it out. You can easily say this is clinical frailty score of 5. Well, is this a reliable predictor of outcome? Does it really matter? Is it relevant? The answer is yes. Okay. And that's what you need to share with your patient and Sajda's son, really, that if you look at frailty score of 5 or over in any of these groups, the ICU mortality and the 30-day mortality in this group is really, really high. Yeah. So if they get admitted to hospital, and every time, if you want to take them to ITU, you know for sure that 3 out of 4 patients in Sajna's case, if they go to ITU, they're not going to survive. The 28-day mortality is as high as that, really. And all this evidence empowers you guys as a trainees, as a consultants, to talk to your patients and have a very informed discussion. Okay, now that brings us to the question number 2. 20% of patients are ineligible for transplant upon referral. Frailty is not an independent risk factor for mortality in liver disease. 20% of patients are delisted whilst awaiting transplant. 3 months mortality of ACLF is 30%. Child C, 2 hospital admissions in 12 months, and performance status of 3 or over have 50% positive predictive value for mortality at year 1. Again, our intention was for you guys to click and see what the audience have said. Unfortunately, that couldn't work. So we'll take you through transplant and palliative care. So 50% of patients are actually ineligible for transplant. The California study group, I've shown you the patients who were pitching in. It was very obvious that only 10% were suitable for transplant, 90% weren't. And if you look at the data from Mayo Clinic, the patients get, and this is outpatient referrals that they're receiving, 50% after they've gone through the transplants were actually not fit for transplant. 20%, and even those who actually get accepted for transplant, still 20% of them, they would get delisted because of deterioration in their health whilst they're waiting. Higher amount and age really associated with greater mortality. So you can tell Sajda's son that, look, she's got a very high MELD score. She's been admitted to hospital for a long time, and we know for sure that these are really, really strict predictors of poor outcomes. Frailty and sarcopenia, she's clearly frailty score of 6 or over, in fact, and they're independent risk factors for mortality, and we know that their outcome in 28 days is extremely poor. So now that we know the evidence behind all of this, how do I then assess? And if I have assessed the patient, really, when and how do I refer these patients? Okay, so I personally use 2 tools. I'm very happy using Child's Abuse score for my outpatients, and for inpatients, I usually use ACLF, and to be honest, because that gives me a ballpark figure of their outcomes. Okay, how do I assess mortality? I've just talked about this. Ben Hudson done a nice work 4 years ago. He looked at 5 independent risk factors. So child C score, more than 2 hospital admissions in 1 year, ongoing alcohol consumption, unsuitability of liver transplant, and performance status of 3 or more. And what he has said, that any 3 or more of these 5 risk factors would have 1-year mortality sensitivity, specificity, and positive predictive value of 72, 83, and 81. So about 80%. So if your patient have got any of these 3, then 1-year mortality is 80% and over. So that's how serious this is. So therefore, we now need to have integral care pathways that involves palliative care, early discussion. How do I do this? Do I need hospice? Not necessarily. Train your nurses, train your teams, have the whole plethora of discussions around the teams on the ward. Okay, so when and how do I refer? We've talked about more than 2 admissions, single risk factor. 2nd, refractory ascites. 3rd, child C. 4th, encephalopathy grade 2 or above. Old age frailty, we've talked in a great deal. ACLF grade 2 or more, and of course AHCC, even if they are waiting for transplant. This will now take us to our 2nd case. Aslam, a 44-year-old man. He's got HCV cirrhosis. He's on treatment, by the way, very recently diagnosed, brought in by a very, very concerned family because he's never been unwell. He's never been to hospital. They didn't even know whether he's got failing liver, right? So they have now seen, they brought him to A&E, and they said he's been unwell for 2 months, fatigue, generally unwell, slowing down, but he's now having some breathing difficulties for the last few days. He does not drink alcohol. He's on no regular medications apart from hepatitis C medicines, and he wasn't really taking any other thing apart from over-the-counter paracetamol. You examine him, he's drowsy, he's jaundiced, he has labored breathing with a moderate ascites and peripheral edema. Temperature is 38, so a bit high, really, 0.3, heart rate 110, tachycardic, bit tachypneic, and sats are clearly low. He is clinically dehydrated, he's got a flap, encephalopathic. Chest, he's got right basal dullness and a bronchial breathing. Abdominal, he's got shifting dullness. We know he's got moderate ascites, we already said, and there was a peripheral edema. Right, let's do some bloods. CBC, hemoglobin 9.6, white cell 18. LFT is bilirubin 12.6, ALT of 86, ALP 174. Renal function, sodium 130, potassium 5.6, urea and creatinine 2.4. Clotting, INRs 2.6. Really, really unwell, isn't he? Chest X-ray confirmed what your findings were. He's got right basal consolidation, ultrasound, shrunken liver, dilated portal vein, but no thrombus, splenomegaly with moderate ascites. Okay, question number 3. He has decompensated liver disease and multi-organ failure. His prognosis is poor. Just treat him on the ward with medical therapy. See how it goes. And he should not be an ITU candidate. All right. He has DCLD with multi-organ failure, poor prognosis, but family wants everything. So he should be admitted to ITU. He has DCLD with treatable etiology and precipitating event. Should be managed locally in whichever hospital he's presented with, in discussion with transplant center. He has DCLD with treatable etiology and should be referred for transplant immediately. What do you guys think is the right answer? Again, we can't really go through this, but let me take you through this. So the answer here is number 3, which is the right answer. He has DCLD. There's a treatable etiology at a precipitating event. Of course, there's an infection on board. He should be managed in, and he can be managed in local DGH, really. And that's got HD or ITU level facilities. And I'm going to talk about in a minute why it helps. He shouldn't be referred to transplant straight away. He needs to be optimized his medical therapy to a certain extent, and then he can be transferred. So what factors here to be considered? Patient factors, of course, assessment factors, how are we going to assess him? What's his prognosis really? And what is the family expectations? Where do I set it? But all of this has to be around evidence-based medicine. And this is where we're going to have our further few slides. Canonic study is a landmark paper. We all know that over 1,300 patients who presented in similar to like Aslam in 29 centers of Europe, and they found that at least 30% of them had ACLF. Is this important for me to know? Why is this not just an acute decompensation? Why is this relevant? Well, no, it isn't really, because if they have organ failure, then their outcome is really, really different. And this outcome is, we're not talking about 6 months, we're not talking about a year, we're talking about 28 days. So if you have 3 organ failures, i.e. your ACLF 3 of them would actually die at 28 days. It's really, really high mortality. However, which is worth knowing, is this. If they have a precipitating event, which is either infection, GI bleed, trauma, or portal vein thrombus, then if you look at this, and that's very interesting, there's a golden window, or window of opportunity as we call it. So look at your decompensated disease patients. When they come with acute decompensation, should you like, they deteriorate, but they don't deteriorate very, very quickly. Their starting reserve is about half, and they tethered along, then they get into multi-organ failure at about week 5, week 6, and then, of course, the actual demise kicks in. Look at ACLF on the other hand. So they came in with a relatively high reserve. Between day 0 and week 1, either it's infection, it's GI bleed, there is something that happens. And you see that from about 80% reserve, they drop their reserve down to about 20%. And within 1 week, there's a very significant sharp decline. And these patients get to multi-organ failure within 2 weeks of them presenting to hospital. And that's really, really significant if they haven't got that right at presentation. So therefore, what is characteristic of ACLF? So previously good or stable liver function, which Aslam had. He wasn't really walking around with large volume ascites. He hasn't been seeing doctors for many years or many months. He was recently diagnosed, not necessarily he was having hepatitis C in the last 2 months, but he was diagnosed fairly recently, right? And he acutely deteriorated because there is a clear precipitating event, which is a chest infection, and that resulted in an organ failure and high risk of death. And very, very important, this is potentially reversible. This is the single most point that I have managed to convince my ITU colleagues when they said, Farooq, you must be joking. Somebody with mortality of 76% at 28 days, you want us to take him to ITU? And my response to this was, yes, of course I do, because it's potentially reversible. If you and I can treat it, and I'm not talking about transplant here, guys. This is where the difference I want you to understand. As long as you can treat the cause, you can support the organs, may that be liver, may that be kidneys, nutrition, may that be lungs. This is potentially reversible. We can make these patients better, but in discussion with transplant center. Of course, that's what the key here. Okay, so as I was making this program for ACLF in our hospitals, we come up with a very simplified, what we call UHL simplified ACLF score. And by and large, we've come up with something that you as a doctor, as a consultant, can do it at the bedside, really, with just 1 or 2 blood results being available to you. Everything on the right side of this red line constitutes an organ failure and therefore ACLF. So if there's no organ failure, you have no ACLF. If you have single kidney or single liver, but creatinine between 175 to 300, this would be grade 1, i.e. ACLF 1, 2 organ failures 2, 3 organ failures, ACLF 3. Why does it matter? Okay, let's go back to Aslam. We're following, he's now day 2. So you gave him maximum therapy, poor response to initial treatment in ED and the acute care ward right next to ED. He was unable to maintain his oxygen on 10 liters, high flow. ITU team came in and they've admitted him to ITU. He was intubated and he was requiring really high circulatory support. Day 2, there was no real improvement. We called microbiologists. We said, look, has a cultures grown anything? They said, not yet, but can we do more broad spectrum antibiotics? So we did. And at this point, we added antifungal in because we weren't really quite sure where we're going to go. We have discussion with Transplant Center and they said, yeah, fine. He's young. That's his first admission. Good baseline reserves. And we will take him if he survives through this episode. You carry him on ITU. Day 4, his inotrope support increased, urine output gone down, and is now requiring filtration. Right. That brings us to our question number 4. Would you maximize his therapy? You offer filtration and you watch for response. No response, it's a poor prognosis. Day 4. Please withdraw the treatment and start end-of-life care. Stop everything. You maximize therapy, you offer filtration, you have a long chat with the family about deterioration, set expectations here with involvement of palliative care. And you say, look, my hands are off, take him to transplant center now. Please don't do this. He won't, at this stage, he won't survive the transfer. All right, no matter how much ventilators and how much you do try and do him to the transplant center. And this is where the discussions need to come in, right? This is where the setting expectations. And let's just have a look at this. So ACLF patients, medical management, ICU for organ support. No ACLF, grade 1, grade 2, grade 3. Clearly, our patients got ACLF grade 3. Day 28, day 90, day 180. Look at their mortality, starting from 87, reaching 96. So even 28 day is around 85%. And even if they do live, if they were to live 6 months, it is extremely, extremely high. You assess for liver transplant, and if the answer is yes, he's a candidate for transplant, then really you really have to think that, do I carry on or do I just stop? So discussion with transplant center, they said yes, he could be a transplant candidate, you need to. So we had a long discussion with the family, but at this point we have told them that we have thrown everything at him. Maximum medical therapy, maximum IV antibiotics, antifungal. He's now not just on the ventilator supporting his lungs, he's actually now on filtration supporting his kidneys. So the organs are now shutting down. And this is, guys, day 4 on ITU. So we've done everything so far, but he's not improving. If I ask, is he still a transplant candidate? And my response to the family would be, if he improves from here, we will definitely have another discussion with the transplant team. But actually, as he is at this stage, he wouldn't survive the transfer, let alone the transplant. So set expectation really, really right. And day 10 came, he was maximum therapy with inotropes. We couldn't increase the drips of noradrenaline as well as all other inotropes. Ventilatory support was on maximum. Output remained quite low, and his peripheries start to turn blue. Now, you and I both know that the only so much of higher inotropes you could give before the peripheral vascular system starts shutting down. And this is really where he was heading to. He's now day 10 on ITU. So we sat down with the family and we clearly told them, look, we are now reaching the inevitable. We are now reaching the stage where everything we are going to do is clearly not going to benefit. If anything at all, it's actually going to make it worse. It will put him on more distress. His body has not responded to whatever treatment we have offered. And by escalating treatment at this stage, we're actually causing this man more concern, more harm, if you like. And because we have been having discussions with the families from the very beginning, they are now mentally prepared to accept that this is the time where we let things slow down a little. So palliative care team came in as well. They saw him, they started him on infusions, and slowly we withdraw the care whilst we kept him very comfortable, started the end of life care. And sadly, this guy died at day 11. Okay, and very quickly, you guys don't have to write or do anything with this. You can take a picture, it's very helpful. That's the system that we have in our hospital. And if you want, we can share it with you. Very last part of the talk, last few slides. How do I deliver palliative care really? We've now talked about, is it required? The answer is yes. No matter where you work, UK, States, Pakistan, rich, poor, developed, underdeveloped, irrelevant, you need it really. No healthcare can compare with this burden. So we need to look after these patients. Okay. So how do I deliver? And for me, what's more important is communication, timing, education. All these 3 things, if you can achieve those, you can really, really make significant difference to these patients. So understanding patient's journey, your patient is cirrhotic, either compensated or decomp. Decomp really got high mortality, we know that. These patients get looked after outpatient, inpatient, or ITU care. If they're in ITU, we know mortality is very high. And I think you and I should really, really do palliative care at every single level. I have shared an outpatient case with you, and I have shared an inpatient acute case with you. We've discussed all the evidence behind it, and you know, in both of these cases, we needed palliative care right from the outset. Okay, please look for opportunities. And what opportunities? On the wards, in the clinic, emergency department, and even an ITU. You need to look for opportunities, really. And if you can have a dedicated person in your teams who's got a bit more interest in this and have what we call as palliative care MDTs. The key to all of this is communication. All of this is communication. So look for opportunities, assessing patients early, communicate to the family, set the expectations right. Okay, this is what we use in our hospital. You're more than welcome to copy this. So whether you're on the clinic or you're on the ward, anywhere, if you have any of this, then you get referred to that palliative care or hepatologist-led outpatient clinic where these patients get seen, and after discussion, they have a documented outcome. So everyone is very clear. Everyone is, they're not having CT scans time and time again, they're not having ultrasound time and time again. And spend time, when you have a documented outcome from that clinic, you sit with the family, give them time. Don't see them in a rush for 10 minutes. Try and see them with the dedicated time. Okay. Important thing is make a palliative care register. And once the patient is on the palliative care register, then you know that he's not a transplant candidate. This has been discussed, and then this will save a lot of hassle for having the same patient with the same test time and time again. And really last slide, time critical. How do I know my patient's got months to a year to live if this first decom? They've got large volume ascites, Child-Pugh A, or encephalopathy grade 1 to 2. How should we manage this patient? Patient-led model. Ask what's important for them. Tell them we can look after you. We may not be able to turn the tide, but we can still look after you. That's not a problem. And year, months, there are things we're going to support. Which patients have got weeks to months? The one who's having recurrent admission, refractory ascites, not getting better, encephalopathy, Child's B, ACLF grade 1. What you do in these patients, you focus more on symptoms. Try and have early discussions about do not resuscitate. And also it's useful to start bringing discussions about home care. If they're financially struggling, if they have supportive family, please try and bring that discussion very early on. And I actually do pick up acute endoscopy in this group of patients. So what if they have large bleed? Okay, if they're uncomfortable, you would as a clinician assess this. Don't have that discussion. And of course, our today's ACLF3 like Aslam, Child C like Sajda, in the end days, and poor response to treatment, prolonged admission, and clinical frailty score of more than 6, like Sajda. And these patients, I stop all the tests, definitely don't do any endoscopy, and we actually start them on anticipatory meds. And these are your midazolam. You can give them morphine in Pakistan, tramadol. Not ideal for liver disease, I don't like it, but yes, it does help pain. So do prescribe it, please. And other things that also help these patients to significant is diazepam. That is available. You can give them, that helps their restlessness or agitation. Last slide, where do we go from here? We've talked about this. Please identify it. You've got tools, they can help you. Have a timely discussion with the family. Communicate and have advanced care planning. And very, very last, very, very important and close to me, education and team building. Train people around you, the nurses, your ward teams, doctors around, make them aware of this and see if you can change the outlook of these patients and their health. Thank you very much. And I will take questions now.